Thrombosis. Hemostasis is a normal, productive physiological process that stops bleeding after injury. But have you ever wondered how a life-saving clot becomes a life-threatening problem? Well, unlike the normal hemostasis, thrombosis is pathological, where there is a formation of solid blood clot inside a vessel due to inappropriate activation of the normal hemostasis. There are three primary abnormalities that can lead to thrombus formation, and these constitute the Virchow's triad. These are endothelial injury, abnormal blood flow, and hypercoagulability. The causes of endothelial injury can be physical damage, arterial disease, hypertension, cigarette smoking, etc. The normal blood flow is said to be laminar, in which the cellular elements of the blood, like the platelets, RBCs, WBCs, flow centrally and are separated from the endothelium by a slower moving layer of plasma. On the other hand, the disturbed movement of the blood flow is called turbulence. Stasis is slowed or stagnant blood flow. It is a major cause for venous thrombosis. For example, the deep vein thrombosis (DVT) of the leg. Hypercoagulability is the increased tendency to clot. It is seen in some genetic disorders, pregnancy, etc. The pathogenesis of thrombus formation starts with platelet adhesion, where platelets stick to the exposed collagen. Then follows the platelet activation and aggregation. The activated platelets release ADP and thromboxane A2. This recruits more platelets, forming a platelet plug. Next step is the activation of the coagulation cascade, leading to fibrin formation. It stabilizes the thrombus. Coming to the types of thrombus, we have the mural thrombus and the occlusive thrombus. The mural thrombus is attached to the vessel wall and projects into the lumen. It does not fully block the lumen. It is seen in heart chamber. On the other hand, the occlusive thrombus completely blocks the vessel and prevents blood flow. It is usually seen in veins or small-sized arteries. If we look at the morphology of the thrombus, the first or the surface layer, which is attached to the endothelium, is platelet-rich. On top of the platelet layer, fibrin meshwork forms lamellae that trap RBCs, creating a firm thrombus structure. Both the gross and microscopy of the thrombus shows lines of Zahn. These are alternating pale and dark laminations or layers. The pale area is due to the platelets that are held together by the fibrin, and the dark area is the fibrin meshwork with trapped RBCs. Now let us compare arterial thrombus and venous thrombus. The main cause of arterial thrombus is endothelial injury, whereas it is stasis for venous thrombus. The type of thrombus is mostly mural in arterial thrombus and occlusive in venous thrombus. Lines of Zahn are prominent in arterial thrombus and they are less prominent in venous thrombus. The common sites are aorta, coronary and cerebral arteries in case of arterial thrombus, and deep veins of leg are common sites for venous thrombus formation. At last, we move to the fate of the thrombus. After its formation, the thrombus can have the following 5 possibilities. These are dissolution, propagation, embolization, organization, and recanalization. Due to activation of fibrinolysis, new thrombi may be removed. This is dissolution. In propagation, the thrombi grows and increase in size. For example, if the thrombus was initially mural type, it can become occlusive type. In embolization, the thrombus breaks into pieces, gets detached from its site of origin, and forms emboli. It then travels to other sites. In organization, the older thrombi are invaded by the fibroblasts and capillaries, leading to fibrosis and incorporation into the vessel wall. In recanalization, new vascular channels are formed within the organized thrombus. This partially restores blood flow. And that wraps up a high yield overview of thrombosis.